our way. So we have an emergency doc, which not a lot of hospitals in the U.S. can say that. About 200 beds, 11,000 or so annual inpatient visits, and about 40,000 ED visits, growing every day, I think. And like most of us now, the bulk of our volume is on the outpatient side. So we've got multiple facilities in the area, but a majority of that is still actually at our physical hospital location. $180 million in revenue or so, and a lot of factors are driving the growth in this area, but still rapid community growth, even with the economy the way it is. Just kind of a nice retirement area, so there's an influx of people. Done some cool things with technology over the years, and hopefully for all the right reasons. So as it says here, 2011, a big year for us. That's kind of an understatement. In 2009, we started the journey towards the migration from Magic to 6L, but we actually went live last March, so it's been almost exactly 1 year ago for us. And we were able to kind of cram that in, go live, bring up CPOE, and do all the things that were necessary to meet meaningful use for last year for us, which was great. So we got to get a little bit of return on our investment from that. Next slide, Tara, thanks. So, you know, I'm sure many of you guys have gone through this process of why migrate in Meditech, you know, from the Magic environment, and what do you have going on. So we had some strengths. We'd had a strong commitment to technology here for a long time. Our senior team, medical staff, and a number of members of our board and everything really saw that we could use technology to improve quality, safety, and efficiencies and things like that. And we had a really strong IT team. I've been here just over 3 years, so most of these people were here long before me, but really, really good group of folks here. We had a number of challenges, though, here to begin with that we were trying to get rid of. A lot of siloed environment, you know, for applications that didn't talk to each other, not really what I call a strong technology blueprint. So where were we going to be in 5 years, and what did we want to do? So while we've done a lot of really nice technological things, they didn't all tie together, and we wanted to clean that up. And number of applications that we just weren't getting the full value out of them. So we wanted to look at, could we condense that if it made sense. And for those of you who are still Magic, you've probably noticed this over the years, but that technology is a little bit outdated, especially the look and feel. And so I think because of that, and for a number of other factors here, physician adoption was just really low. And so that was something we wanted to take care of with our migration. But many challenges with that project is you can guess, or you may be going through yourself. So some of the things that we knew in advance 2 years ago when we sort of started the implementation that we had to be aware of as we move forward. One thing was we'd already tried CPOE here. That was in the EDM product of Meditech Magic, and they had failed miserably. Fortunately, it was before my time, but I think it was a number of factors. One, probably the way we did some things, the way Meditech worked, and just the look and feel of the Magic was just not conducive to workflow. So we knew we had to deal with that through this. Our integration, and that's what this focus is really on, was really a mess back then. And there'll be a picture in a few minutes that sort of shows you what our before picture was. But we had just a number of point-to-point interfaces, scripted interfaces, kind of third-party proprietary things between Meditech Magic and some of our third-party applications and other devices. So we had to address that. We really wanted to kind of wrap around the right things with this migration, eliminate vendors where we could, and bring in the right vendors, you know, or to partner with us for the places where it made a lot of sense. And I'll talk about that. And we really looked at the 6.0 migration as the chance to really use their new system, as good or bad as it may be for people, but use it as effectively as we could, which meant changing what we do. I mean, a lot of process redesign, and I hate using terms like that, but that's really what it was. And we did things as fundamental as changed our employee numbers, our general ledger chart of accounts, our user IDs, all for the right reasons, but it just really brought a lot of change to us. So we knew it was something we had to focus on with our training and kind of marketing of it. Definitely you need a different kind of an infrastructure before you're ready for 6.0. Many places have that in place right now because you've kind of grown with some other things, your PACS environment or whatever it might be, but definitely different infrastructure than you've had in the Magic world. And for us, particularly then, 6.0 was still somewhat immature, still to some degree. As some of the last releases have really made some improvements. I'm looking forward. We're going to 6.06 in the next couple of months, and that's going to be really nice for us too. And it's expensive, and so one of the things that we decided up front was that we weren't really going to use consultants to help drive our migration. We wanted to kind of save that funding for certain niches where it made sense for us, that we just didn't have the expertise, but just from the general project perspective and having the clinicians and all the other people, we wanted to use our own folks here, both in IS and in our departments, because they're really the experts that we had, and we wanted to keep that knowledge moving forward after we were live. So, what do we do to sort of try to overcome some of those challenges? And I'm sure you've all recognized this. You need some physician champions. We actually employed a CMIO at that point. Since then, we've actually employed pieces of other physicians that are actually all working physicians. Only one of those folks is an employed provider. The rest are all still private practicing physicians that spend a little bit of time with us. It's helped immensely. For us, since we'd failed with EDM, we knew going into the 6.0 world, looking at and evaluating that system, it still wasn't going to be right for us. So we chose to go with a third party. Maybe not the right decision for everybody. For us, we felt that it was. We knew because of that there was going to be a lot of integration needs to make that work as smoothly as we could. So I figured that was incumbent on the IT folks, and that we would just make that work. So that was kind of one of the other challenges. We had to find the right integration vendor to work with moving forward. Probably one of the 3 or 4 biggest components of the migration project really was the integration piece. And you'll see from the drawings here in a little bit, we have a lot. I don't think we're unique in that regard from all of you, but we had a lot of integration to consider, and how are we going to do that, become more efficient, give us the ability to grow and expand as we needed to, and be kind of flexible and nimble for everything going forward. The budgeting for consulting, like I talked about, we chose to not bring in one of the, whether it's Dell Services or all the other folks who have helped other people migrate. And at the time, I think we were the first migration customer who went that route. Got a lot of pushback from, of course, all those consulting vendors, but I'd stand by that. I think for us it was still really a good choice, and honestly saved us probably at least $1 million in the migration. And I imagine we're not dissimilar from most of the rest of your organizations. That's a lot of money for us, and we used it in other areas that I think was more important. But we did reserve some money for the right things if we just didn't have the expertise for it to help get some projects done and completed. And then, there's just all sorts of other costs and things that pop up as you start the migration. You've got the hardware, and that big pieces, the migration from Meditech and some of those other things. But as you're starting to look at even the integration, how are you going to do that from your magic world to the 6.0 world? And the interfaces change, and actually better. You can go to the next versions of HL7 in many cases and get more flexibility and more data that you can move. But it's a massive project. You got all the third-party vendors you have to consider, what their interface costs are, and a lot of those things that some of them we thought about in advance, and some we just didn't. And we learned our lesson. And I've kind of said before, at one point I just got kind of numb to signing purchase orders for little bits and pieces to everybody that needed it, because we just needed to move the project along. One of the other big challenges, I think, is communicating to your own internal staff. What the project is. It's not an IS project. It's definitely a hospital-wide initiative, and everyone needs to get involved. And that took a lot of effort from us. And then we learned from the even earlier adopters. There were 4 live when we went live, and those guys, I kind of say they took one for the team, because they really struggled going through that migration and getting to the point of the product become a little bit more mature. And they're doing great today, and there's even more now. I think we're at maybe 79. I think I heard Meditech say recently live sites with 6.0 to some degree or another. But while we were doing all that, we wanted to think about at this point now meaningful use was out. It didn't exist when we started this plan, but since it existed, we wanted to make sure we kept that in mind. And then future things, connecting. We've got a statewide HIE going on, integration with our community physician offices, which we'd always done historically from just kind of a passive posting lab results and radiology reports, but we want to actually grow that as we move forward. So the integration piece that I talked about, and it is a big, big piece. Even though we're primarily Meditech, we still have other systems, and I think everybody does. You at least probably have a PAC system. We use Pyxis dispensing machines. We have GE, Centricity fetal monitors. We have Space Labs of physiological monitors. We now have a MedHost system in our ED. all our physician office integration, and a host of other things. So it is a big component of the migration. And for us, it was probably one of the 3 or 4 biggest things that we did through this, and the biggest being just the build of Meditech itself and what that monumental thing is. But the integration was key. We knew that it had to just work and be invisible to everybody when we were done. So I think I mentioned our old environment was really clunky. In fact, we just couldn't even get our arms around what we had. We'd used Meditech Magic for over 18 years by the time we converted over to 6.0. So we had a number of Meditech interfaces. We had a number of third-party kind of proprietary interfaces. Some were scripted in, some were true HL7, some went through a kind of an antiquated router type of a solution, but not a true robust engine. And we had some physician office integration, but they were each treated as separate point-to-point interfaces. We had a few custom interfaces in the Magic world, and we had to kind of evaluate what that would look like going to 6.0 through the project. And then I mentioned that you can really take advantage of some nice changes with newer versions of HL7 available to you in the 6.0 world. So that has to come into what are you going to do as you do the integration and the migration project. Didn't want to risk any failure with interfacing, so that was a big deal to us. And so, when we evaluated what we had and how we were going to move forward and looked at the different vendors that could work with us, it didn't take long to figure out, what made the most sense was to put in a true engine, eliminate all the point-to-point stuff, and move forward with that. And I think I speak more to that in some future slides, so I think we can go, Tara. So here is, while this is a pretty picture, this is our before picture. It took us about 3 months worth of work just because we didn't even understand internally how all the interfaces worked and what we had in place. Nor honestly, our kind of incumbent vendor who helped us with a lot of the interfaces, they couldn't even explain how it all worked once we came down to evaluating what we needed to move forward to 6.0. So while this picture looks pretty clean, I think what you can see out of it is Meditech's at the bottom, and there are a few things that go in and out of that, and then go through a router and a lot of scripts and a lot of kind of proprietary information, and then off and back and forth from our different third-party applications or devices. And in a few minutes, I'll have a kind of an after picture of what it looks like, and it's kind of hard because the drawings are so clean to understand the distinction. But if I could describe it, this is like a giant mess here, even though it doesn't look like it. And like I said, it took us months just to even kind of draw this and figure out exactly what we had from what to what after 18 years worth of growth. So when we looked at the options and what we could do, some of the things we wanted to make sure we factored in was something that would grow with us. So we wanted something that was more robust than just reintroducing a bunch of more point-to-point interfaces, because that's definitely doable in the 6.0 environment. It just doesn't make sense, especially not knowing what the future holds and wanting to be a little bit more nimble and flexible in the future for us. So, that scalable component of an engine was key for us. We needed a partner, so this was kind of an area where we decided, I don't have the internal expertise. We're still a relatively small hospital. I don't know if I mentioned up front, we got about 22 or 23 people in IS total, so that's our technical group and our applications folks and everything. And no one specifically trained to do integration. Different analysts had worked with different vendors over the years on their particular modules, but we didn't have one kind of integration expert. And I knew that, and this was just a spot where it made sense to bring in someone who'd done it before, particularly done it in the 6.0 world. So even though there were only about 4 or 5 live 6.0 sites, someone had actually done some of those migrations before and had good success. So we ended up also with the MedHost that we talked about, and again, finding someone who had some familiarity with that, and just the familiarity with wanting to explore deeper integration with products. You create your own challenges, I think, when you go to some best-of-breed vendors and you get out of the fully integrated Meditech world, and I guess I should say fully integrated with a grain of salt because they still are interfaced from module to module. But, there are just some applications that we felt weren't strong enough for what we wanted, knowing that meant we would have to integrate it better. And so that's why it was just key for us to work with a partner that could help us do that integration, drive it, work with those vendors to actually improve what they'd probably done before with other Meditech customers and build upon that. And there are still some things are not HL7. You know, it's getting better all the time. Some of that's a Meditech limitation because the HL7 segments might exist, but they don't allow them to be imported or something. So you still have to be able to script and some of those other tools. And so we want to make sure we considered all that. The total cost is something you have to factor on everything. I mean, we're always looking at if a project has an ROI, what it is, or what the cost is. Is there a way we can become more efficient with that? You know, every month it seems like our reimbursements are being changed from all of our payers, and you guys are no different. And so we're trying to always do more with less. So from the integration perspective, there was the software cost, the cost of the project itself and whatever development service go on with that, but then also the ongoing maintenance fees. And for us, getting away from that point-to-point world where you're paying for 125 to 150 separate interfaces to be maintained on an annual basis, and getting into a true engine where you may have maintenance on that software for that engine, but the interfaces are yours. You know, and once you have them, you use them multiple times. Definitely knew we wanted pure Meditech feeds in and out. So essentially for almost everything that Meditech offers, I think we now have purchased that. So that's a cost up front that you have to pay. Most of them are not too bad, in the $10,000 range. Some of them are a little bit more. But you buy them once. It's a clean feed with Meditech. They work really well with you then as you're doing these integrations. And so you just got that going forward. And then you route those through the engine and can use them multiple times. And then part of the total cost was the other vendors. And I mentioned a few minutes ago, we didn't even have test environments for a lot of these vendors we found. So we had to build a test environment. We had to, build the 6.0 test for them. And so some of those folks had fees, some of them didn't. It was part of our maintenance, but it's just something to be aware of and what that looks like going forward. So choosing the right technology and getting the engine in place, and that's key. I think the sooner you can start with this whole concept of the integration, because it seems like it's kind of a transactional thing that you take care of while you're doing the migration. To me, it was really a strategic decision, and I wish we'd almost made it sooner, although it seemed like we were working as quickly as we could. But I would definitely recommend the sooner you can come up with a decision on this, the better. And we did obviously choose Summit to help us with this, and so we implemented their engine. Now, in March 2011, that's actually when we went live with Meditech 6.0. So we actually got the engine in probably not quite a year before that, which is about consistent with when we started our implementation with Meditech for the migration. We ended up with over 150 interfaces routing through the engine. And the beauty part was, even though it's a much more sophisticated environment than we had before and more nimble and flexible, and I can grow as we need to grow, I'm actually saving money today over what I was paying in the old Magic world just on an annual maintenance perspective. And again, that's kind of due to getting away from all the point-to-point interfaces and having a clean engine running. So we did buy some feeds from Meditech. We bought the software from Summit. And then because we just didn't have that expertise, we engaged Summit for their migration services, and probably even just as relevant from an ongoing perspective, they do some outsourced services. So we've got some people at Summit that, as far as I can tell, they're only ours. I know they're doing this for other customers, but it seems like they're only ours. And so everything that we do, is because we're still adding more all the time, that's the expert, and they drive the process for us. They know the third-party vendors. They know what the engine's capable of. And we could train someone to do that for ourselves, and it just hasn't made sense to me because of our scale. We're just not big enough. So it's easier to outsource that, and that's worked fantastic for us. But even within that whole context of paying for the migration services, which was a phenomenal effort, and continuing the outsource agreement, I'm actually paying less money today for integration than I had in a really kind of defunct system before. So that has worked out very, very well. But still planning, still doing more things in the future here. So here's kind of our after drawing from after we went live. I think this may be just a bit outdated now because we've added a number of other things, but the key to this is what you'll see is you see Meditech at the bottom. You see a lot more interfaces in and out of Meditech. Those are true Meditech interfaces that we either had licensed to before and they converted to 6.0, or we've purchased since then. Because remember, the goal was to get rid of all these proprietary scripted one-off interfaces. We route all of those things into the Summit engine, even if it's only for one vendor today, just because the engine can kind of maintain what's going on, give us status reports, alert us when things are going wrong, much quicker than what we get out of the NMI side from Meditech. So everything routes through the engine because someday we may use it again. And then you can sort of see a lot of the same vendors on the other side with the two-way communications for everything. One thing that is maybe not real obvious is down on the left-hand corner there's some of our physician office integration. We've got, and that number is even bigger now, but we've got a number of offices in the area, both that we have employed physicians at that run Allscripts or others that run Allscripts here. We also integrate to eClinicalWorks and Greenway, and another one just popped up in our community, so we're going to have to figure out how to communicate with that. Today, we're still sending lab results, radiology reports, and all that, but we're actually almost ready for testing, or we are testing, I guess, a true physician office integration, which will take registration. So if we get a reference lab or imaging order from a physician office in our community, we'll be able to actually pre-register the patient in Meditech. When the patient shows up, we can complete that registration really quickly. It'll populate the order into Meditech automatically for us, and then based upon that, has kind of the ties everything together to send those results directly back into the EMR system on the ambulatory side. And that's fantastic. And so our community is really looking forward to that for us. But the key, even though this picture looks very similar to the other picture, it is, the other one was maybe organized chaos, you could say. This is an organized, healthy system that's easy to understand, maintain, and grow. And that was a ton of work to get to that point. Even the drawing was a lot of work. But next slide, Tara, please. So, you know, the physician office piece I was talking about, and I'm sure many of you guys have done this already, is there are a lot of different EMR systems out there, and you can't tell people in your community what to buy. It'd be nice. We even tried some efforts here long before I got here to host Allscripts for private practicing providers in our area, and some people jumped on board with that. It's probably the world's worst business model because we didn't charge them for it, and so over time that's kind of gone away because they could see it would be better for them to be on their own system. But you know, we've got a number of different systems that we need to talk to, routing that information back and forth, and the bi-directional. I think that's key. You know, we use Allscripts for our own employed providers, and we have some cases where we've got a location about 20 or 30 miles from the hospital that we have a lot of outpatient services that are hospital services, imaging, laboratory, and some other things, and a primary care physician office which uses Allscripts. And so to the patients, they look one and the same, but since we were using different systems, the physician may see a patient write a lab order, the patient walks across the hall into another door that has our same logo on it and has to go through a complete registration process again in Meditech, and it's a huge dissatisfier for the patients. Not to mention, you know, a place when we're entering information manually 2 different times is a good way to make some errors. So that's why I'm really looking forward to the provider exchange being live, and we'll actually send that registration information over from the third-party EMR system using the Meditech inbound ADT interface. Will populate pre-registration essentially, and so when the patient does walk over there, as soon as they present, whether it was across the hall or 3 days later from across town, populate the registration, the order itself then imports automatically into Meditech, and then we complete that order and send the results back through. So that's going to be a big win for us, and we offer that to every provider in town, whether they're employed or not. We definitely want their referral work, you know, so we're going to try to make that as tight as we can for everybody. So now the meaningful use stuff, and everyone's kind of scribbling for that, and now we're trying to figure out what stage 2 really means, you know, down the road for us. But where the engine came in place for us, and again, it's just the ability to leverage something that we already had in place and not have to spend more money. So we are routing things through the engine for some of the menu options that you had, whether it was the immunization, the lab data, or the syndromic surveillance, in communicating with physician offices. So again, staying away from the point-to-point stuff, even though we may only ever do these things one time, I think we'll be doing some of them multiple times. data to come from where, go to where. So today is kind of up in the air, but we're going to, for instance, we're going to purchase a patient portal solution, which we'd be able to aggregate both Meditech data and physician office data, not only from our employed providers, but also community providers, and get kind of one community record available for both the patients to view and look at, which they should, but also for our clinicians to view, so that if someone presents in our ED, they can see what's been happening at their primary care or the pulmonologist office or whatever it may be, at least from a CCD perspective, which isn't everything, but it's a good start and it's some good data to have back and forth, and definitely want to leverage that through our engine moving forward. So I think this is just kind of a graphic that talks about, all those things I've been mentioning, that we want to have one really good interoperability platform in the middle that just gives me the ability to answer whatever the question is in the future. I don't know what that is, but now I've got something robust. I've got good, clean data coming out of Meditech, going into Meditech in every instance, and then I can reuse those for whatever pops up. Today, some of the things we're working on, the physician office integration piece that we talked about, we're tightening our integration with our third-party ED system, MedHost, so that we'll have a true pharmacy integration, which that's always been the downside if you go outside of Meditech for that. So when we're finished with this component and all this is going to route through our engine, it'll actually be a physician order in our ED system, populates an order in Meditech, populates the profiled med in our Pyxis dispensing machines. So now the nurse is taking out a profiled med that's there for that patient instead of an override medication. That gives us the ability to do a true bedside administration that's meaningful at that point, because now we can actually administer and acknowledge that we're giving the right med that the physician ordered for that patient, not whatever the nurse took out of the Pyxis machine. So it's a really tight piece of integration, and I think it's kind of exciting for us. And who knows what's coming down the road, as far as all of the other HIEs and what's going to really happen with a national record. But at least now I'm really comfortable that we've kind of got the ability to keep growing with what we've got from an infrastructure. So from our 6.0 migration, this was one of my 4 or 5 key challenges, I think, is what are we going to do with all of the interfaces we have in integration? And I feel like we answered. I don't do a lot of things right. I think this is one thing I did right, and we're still very pleased here that we made the choices that we made and moved forward. And I think, Tara, that's the end of me, and then Matt gets to kind of show off some of the technology.
Yes, thank you. I appreciate it, Ed. Thanks so much. For the folks on the line, what I was thinking now is we could go through just a short demonstration of the interface engine, the Express Connect technology, just so you can kind of see the look and feel, how the interface components work, the mapping and the filtering, and Matt was going to go through and just show that as well. Also go through a short discussion on the provider exchange as well, just from a workflow as Ed touched upon. I will be getting a copy of the PowerPoint out to everyone, so certainly we'll get you a copy of that. So with that, I'm going to go ahead and just turn it over to Matt. He's only going to do about 10 minutes or so, and then we could open it up for questions as well while Ed's still with us here. So Matt, I'm going to make...
Every hospital, every healthcare facility, here are data elements you must submit. You must submit them electronically. You do it to get paid. So we can figure out how to do that to get paid. I think we could figure out how to do it to our EMRs, but it's not. It's just way too vague. So until then, we've decided to sort of build a community record here. And the way we're going to do it, and there's probably a number of ways to do this, but is through a portal, so that we sort of kill 2 birds with 1 stone. We give the patients the ability to view their record and maintain some personal health record components of it that might not have clinical relevance to our providers, but give us a clinical view into that data. And there are ways to do that so that you protect what should be protected, and the components of the record that the patient doesn't want to go on to others and things like that. So yeah, unfortunately, we've decided that we're going to probably have to host that to be successful in our community, and that's our mission, is to do this to improve the wellness of our community.
Thank you. And another question in regards to redundancy, in terms of backing up, are you leveraging like another server for redundancy, or like a double take solution? I don't know the model there.
We
Do you know?
do. So yeah, I mean, so on the Summit side, we've got another server. So if one server's down or whatever, our interface engine doesn't go down. From a data perspective, all of our data is replicated off-site real time. So both our live data, our archive data, and even our backups now, we've got 2 completely live replicated sites.
Okay, excellent. Thank you. That is all of the questions I have here in the question box. We're just shy of 1 o'clock, so we kept with the time pretty well. If anyone thinks of any questions, as I mentioned, I'm going to get a copy of the presentation out, which will have both contacts from Summit as well as Edric as well. So certainly encourage you to reach out to us if you need any additional questions answered. And we hope this was beneficial. We also do plan to offer a similar presentation at the Meditech Users Conference at the end of May. So we do encourage you folks, if you're attending that show or having other staff members, please do join us on that presentation. We do have one other question. I don't know, Ed, are you interfacing any vital signs into the EMR?
We do. So we purchased the Meditech monitor interface, which is available in 6.0, and we've used it 3 times now. So we bring things in through our fetal monitors. We bring in vital signs and other physiological data through our Space Labs monitors. And then we just bought, and we're not live yet, but we will be fairly soon, next couple of months, Welch Allyn vital sign monitors to replace all our Dynamaps, and they're wireless. So they're going to automatically import right into the PCS information using the same interface.
Excellent. Great. Well, thank you, everyone. I hope you got a chance to enjoy your lunch. I'm sure Ed and Matt are hungry, so go ahead, and we appreciate you joining us today, and we thank you for bringing this great message and your experience to the Meditech community. With that, I'm going to go ahead and close the webcast. Have a wonderful day, everyone, and we look forward to speaking with you soon. Thanks so much, everyone.